So now once you have a confirmed GTN that the HCG level has plateaued or the HCG level is rising, then you have to stage the malignancy. So often you would already have done an ultrasound of the pelvis or some imaging of the pelvis prior to the referral. Once the patient comes to us with this, with these reports, with an ultrasound done outside, HCG level is plateaued or it's rising, then we would want to see whether the patient has any distant metastasis or not. So an initial chest X-ray is the imaging of choice to look for any lung metastasis. If the X-ray is normal, usually no further imaging is required, especially if the beta HCG level is not very high. But if the X-ray shows you some suspicious lesions, then you would have to do a CT chest. If the CT chest again shows big lesions in the CT, that indicates that the patient has probably a high risk of having even brain metastasis or even liver metastasis, especially if the HCG level is more than 4 lakh units. That is when the patient would require an MRI of the brain or a MRI of the abdomen and the pelvis. So once your entire GTN is confirmed, your staging is done, and you know where all the metastases are located, then you would score this patient, and this is very important. This is the FIGO risk stratification system. As you can see, there are 8 criteria on which you score the patient from a range of 0 to 4. So younger age is given a score of 0, age more than 40 is a score of 1. What was the antecedent pregnancy? Was it a molar pregnancy, or was it a miscarriage, or was it a full-term pregnancy? The score again goes up. What was the interval from the index pregnancy? That is important. What was the pre-treatment beta HCG value? And mind you, this beta HCG should not be very old. This should be a HCG level done just 24 to 48 hours before the initiation of treatment. Often we see HCG values being done in other labs not being very reliable, and our HCG values at a very standardized lab are very different from what we see from outside labs. So we repeat an HCG just before we initiate the treatment. We look at the number of metastases the patient has, what are the sites of metastasis, and whether the patient has previously been exposed to any chemotherapy or not. And then all this, the patient is scored on all these parameters, and then you get a final risk score. So any score that is less than 7, 0 to 6 is a low risk GTN. So these are the typical patients who would probably have a beta HCG maybe around 10,000, 20,000, 30,000, probably less than 50,000 to 1 lakh. These are the patients who would probably have would be having a history of a partial mole or a complete mole before presentation, and they would not have any distant metastasis to the lung or brain. These are the patients you would come across most commonly. 80 to 90% of your GTNs will fall into the low risk category. Sometimes in high volume centers, in a tertiary cancer institute per se, like where I was trained in Tata Memorial in Bombay, we would see a lot of high risk GTNs as well. And these are the patients who would have florid lung mets, brain metastasis, liver metastasis, HCG levels in several lakh units, so much so that even with serial dilution, the final HCG levels are not clear because they are so high. That is known as high risk GTN, and that's a completely different ballgame, and it's a medical emergency. So how do we treat low risk GTNs? So low risk GTNs with a score of less than 7 are treated with single agent chemotherapy. There is no other malignancy which can be cured with single agent chemotherapy, and the most common drug that we use is Methotrexate. I'm sure all our obstetricians are well aware of this fact. What is important is that the dosing of Methotrexate is very important, because Methotrexate often when it is delivered elsewhere without the supervision of an oncologist, it is not given at a right dose, and then the patient becomes resistant to this drug, and then we have to use other salvage regimens to cure the patient. So we'll come to the dosing in some time. So once we start the treatment, we are supposed to keep monitoring the HCG levels every 2 weeks, that is after each cycle. Most patients you would see that the HCG levels would normalize, and then these patients would be followed up for the next 1 year. Some patients who have a good response to the initial treatment, but again the HCG level starts rising, you are supposed to put them on salvage treatments. So this is the most important regimen on top, the MTX folinic acid regimen. This is basically alternating doses of Methotrexate with leucovorin. And this 50 mg MTX dose is now considered to be a little bit underdose. It is actually 1 milligram per meter square. 1 milligram per kg, I'm so sorry. So if the patient is around 65-70 kilos, you're supposed to give 70 mg Methotrexate on day 1, 3, 5 and 7. And on alternate days, day 2, 4, 6 and 8, the patient takes a leucovorin tablet. This is a very easy to administer regimen. Probably first cycle we give it in our hospital under supervision, and the remaining cycles the patient can even take it at home as well. Now, like I said, those patients who have a good response with the HCG levels, but again if the HCG level goes up, you're supposed to switch to the alternative single drug, that is actinomycin D. But those patients who have very high shooting up HCG levels, you have to switch them to a multi-agent regimen known as the EMACO regimen. For patients who have high risk GTN, those who present with lung metastasis, liver metastasis, or brain metastasis, and they have very high HCG levels in lakhs, these patients cannot be cured with single agent systemic therapy. They need multi-agent therapy, and I'm sure that all of us have read about this regimen, the EMACO regimen, which is basically a combination of 5 chemotherapy drugs which are given in a particular order. And even once the patient is on EMACO, again you have to check your beta HCG levels every once in 2 weeks. And depending on the way HCG levels are responding, you're supposed to decide how many cycles you're supposed to give the patient. Sometimes some patients, they have, especially high risk GTN patients, you would see some of them patients not responding completely to the beta HCG, and the beta HCG plateaus, or it again starts going up. That is when you have to switch the patient to a salvage therapy with the EMAEP regimen, which is the most commonly used salvage regimen. So let's not go into the detail of the EMACO regimen. Basically, like I said, it's 5 chemotherapy drugs: etoposide, methotrexate, actinomycin D, which is given on day 1 and day 2. And on day 8, you have cyclophosphamide and vincristine. So vincristine is also called Oncovin, that is why EMACO.